In this video, we'll go through problems that can arise very early on in life, the in utero injuries. We'll start off with neural tube defects, which are shown in this cartoon here. Then we'll move on to some chromosomal abnormalities, that is Down syndrome and Prader-Willi syndrome. So all of these problems arise before you're born, although they might not necessarily manifest until a little bit later in life. Now, the neural tube defects are caused by issues with neurulation, that is, separation from our nervous system, from the skin, as well as abnormalities in skeletal development. So this cartoon, this cartoon over here on the right is starting off before gastrulation here. So the primitive streak just establishes the anterior-posterior axis. This will be the head, this will be the tail. Now we're finally forming a structure that we care about, the neural plate. That's this kind of light blue thickening of the ectoderm. In the middle is a neural groove, and that's what it sounds like. It's a little groove that's where the nervous system is going to fold over. So here we can see it folding over. We're going to zipper up here. This will be about a little below the back of the neck, and those neural folds will then fuse with each other. And we're going to zipper up and down. It's highlighting the somites now. That'll make the musculoskeletal system, which is very cool. And what we're left with is a nervous system that's now inside of the animal. So what we should take away from this movie is that the nervous system starts on the outside, and then through the process of neurulation, folds over and is then contained inside. That means if anything goes wrong here, our nervous tissue might not get folded and put inside our bodies. And that is a neural tube defect. All right, let's take a look at this in cross-section here. So if we slice through that developing embryo here, we can see our three primordial layers here. We got the ectoderm on the outside, mesoderm in the middle, and endoderm on the inside. Endoderm will make our viscera. That's really cool stuff. We're not going to talk about it. The mesoderm is super nifty because it makes the musculoskeletal system. It also forms this little structure called the notochord, which is pretty darned handy. It's going to attach to the overlying ectoderm and anchor it in place. So it'll establish our midline. The ectoderm is where all the magic is going to happen because the ectoderm contains the neural plate. This is your future nervous system. And the rest of the ectoderm, this green part here, is going to form the skin. So what we need to do is take a sheet of tissue, that is the neural plate, fold it over, and hide it away inside the cell. So we're going to go from a sheet to a tube. And that tube is going to be covered then with a sheet of skin. This way our nervous system is safely hidden away from the outside world. If you expose any cell to air, they die. So we need to hide our nervous system away, and that's what goes on in neurulation. So note here that the nervous tissue is connected to the skin. And it is over here when we have these neural grooves, and at some point we're going to have to do the old cut and paste. We're going to have to cut this connection here and here between our nervous tissue and skin, and then paste only nerve cells together and paste only skin cells together. If you like electron micrographs, here's what it actually looks like. I think the cartoon does a pretty good job of explaining it. So the way that we fold over is by cell division and growth, and those migrating, growing cells move toward the midline. And to hold us in place, the notochord here anchors itself to the overlying neural plate. I'll draw the two lines since I use that for fusion over here as well. That way, as cells are migrating, rather than pushing around the ectoderm, it causes it to grow upward, forming the neural grooves and the neural ridge. Then we do the old cut, paste, and we zipper up those neural folds. That fusion begins in 2 to 3 locations, depending on whether you're a mouse or a human. If you're making any sense of this video, you're a human. So we only have 2 closures. One around kind of the back of the neck, which zippers toward your head and tail, and then another one around the front of the head there. Mice have an extra one. Okay, fair enough. What they're highlighting down here is that this human embryo zippers up here, and the asterisk is to show you that we have a small midbrain compared to mice, for what that's worth. So you can disregard the asterisks. Okay, so our neural folds meet up with one another, and through the magic of protein interactions, separate from the rest of the ectoderm. That separation isn't clean, though. Sure, we're going to take our neural plate and turn it into a neural tube. And that neural tube is going to form our central nervous system. That is the brain and the spinal cord. But that's not all of our nervous system. Some of these nerve cells need to migrate away and go live in different parts of the body. That's where the neural crest comes in. And I like to think of these as crumbs. So sometimes I'll just, in my head, call them neural crumbs, but they're called neural crest cells. Anytime you slice some bread off of a loaf, you're left with some crumbs, and that's what's going on here. We're going to slice off this bit of the ectoderm from the rest, and we're left with some crumbs. These crumbs allow for cleaner separation of the neural tube from the overlying skin. And because they're not attached to either one of them, they are free to migrate along a couple of different pathways. Some of them are going to go live in the skin. So even though they separated from the skin, they'll be back, and they'll form those melanocytes, which have those elaborate extensions, if you recall from physiology, that allow them to distribute melanin throughout our skin. So they kind of look like neurons, and that's because they are derived from similar embryonic tissues. Others will migrate along a different pathway, forming all the rest of our peripheral nervous system there. So they'll form the dorsal root ganglia. They'll form really any of the ganglia out there. They'll make the Schwann cells. They'll go live in the gut and give it its enteric nervous system. So neural tube makes the central nervous system. Neural crest makes the peripheral nervous system. Now, primary neurulation, where we go from a sheet to a tube, makes almost all of our central nervous system. The last little bit of the spinal cord, so those last few sacral segments and the coccygeal segment, are made through secondary neurulation. And in this case, we're not going from a sheet to a tube, we're going from a rod to a tube. So rather than building on the outside, we build this medullary cord under the skin, so no risk of an open neural tube defect here. Any problem with secondary neurulation is what we call a closed neural tube defect. So we make a rod, and then it grows outward in a process called cavitation to make a tube, which has a cavity in it, hence the name cavitation. Then it fuses with the neural tube made in primary neurulation. Bing, bang, boom, you got yourself a central nervous system. Now, the other structure made by secondary neurulation is the filum terminale. And this is a little bit of connective tissue that runs from the bottom of the spinal cord to the coccyx and helps anchor the spinal cord in place. Rather than cavitating, instead the medullary cord degenerates a bit to form a thin strand. Now, if we were to slice through and look at a cross-section of the vertebral column, we'd see that it looks quite different if we did that early on in development versus at birth versus in adulthood, which is not on this slide. So a few things to keep in mind when we form our vertebrae. This is made from 3 structures. 2 of those structures fuse. So the first structure is the centrum, which is actually derived from the notochord. So not only is the notochord nifty because it anchors the neural plate through neurulation, but it also then forms our vertebral body. So first we call it the centrum, and then over here we call it the vertebral body. The neural arches are these paired structures over here. So this is going to form the vertebral arch, but first they have to fuse. So that means that these bad boys have to grow toward the midline, fuse together, and form that single vertebral arch. So if there's any problem with growth and these two structures here don't meet up, we're going to have an opening that this nervous tissue could potentially herniate out of. And that, ladies and gentlemen, is spina bifida. One last thing to think about before we talk about the neural tube defects. So we've separated our nervous tissue from the skin, and we've built our vertebrae. This is all wonderful. We're going to continue to grow now. Here's the deal, though. Our nervous tissue doesn't grow at the same rate as our skeletal tissue. So as we go through development, the spinal cord seems to ascend upward. Rather than being down here at the bottom, it kind of creeps upward into the lumbar spine. It doesn't actually ascend. The thing is, the spine just keeps growing. And the spinal cord stays about the same length. Now, it's still rooted in place by that filum terminale. So here's that little bit of that medullary cord that degenerated, and it's holding the bottom of the spinal cord to the coccyx, helping to anchor the spinal cord a bit. Now, these spinal segments that don't have spinal cord in them, of course, still have nerves coming off. Don't forget, we got the good old cauda equina. Go back and review physiology if you've forgotten that. So there's a bunch of nerve roots coming down here, not just at L5, but also 4 and 3 and down here in the sacral spine as well. If we have any problem that, for example, tethers the spinal cord in place, maybe there's some kind of, fatty outgrowth here that holds the spinal cord in place, rather than ascending, that fatty outgrowth down here is going to stretch our spinal cord downward. And that is tethered cord syndrome. That stretching is going to put mechanical forces on the spinal cord, and that's not going to end well. All right, neural tube defects. We can see the prevalence here. So fairly common, second most common birth defect, right behind congenital heart diseases. The risk factors here are, of course, a family history. If there's a genetic cause, it's likely to be shared in families. Teratogens, that is compounds that interfere with development, can increase the risk of neural tube defects. So if mom is taking anticonvulsants, she'll likely need to lay off of those for the first trimester or so. Of course, anything that deals with nutritional status, so maternal diabetes and obesity are risk factors because they can interfere with nutrition to the fetus and thus interfere with its growth. And a big one here is folate insufficiency. And I say this is a big one because this is highly treatable. And in fact, maternal vitamins, neonatal vitamins, contain a lot of folate because folate is very important for growth. And so this is an easily addressable risk factor that we commonly take care of nowadays. Okay, so what's going on in neural tube defects? Well, anything that interferes with growth and division is a risk factor here. That's what's causing it. We don't properly grow. And so in normal development, right, this neural plate here, we got our grooves, we're growing to the midline. Hey, they meet up and then close at around day 22 in development. In order for the neural grooves to meet up, we've got to grow and we've got to move toward that midline. But if growth is slow, let's see. Okay, let's do it up here. Nice solid line, solid growth. If growth is slowed down for some reason, then our neural grooves don't meet in time to fuse, and that leaves us with an open neural tube. So what might slow down growth is really anything that interferes with DNA synthesis, like histone deacetylase inhibitors. So valproate. This is an anticonvulsant that will actually slow down the rate of DNA synthesis. So if we're not making our DNA as quickly, then cells can't grow and divide as quickly. Therefore, the neural grooves aren't going to meet in time. Folate deficiency, whether it be dietary or because of some teratogen that interferes with folate transport, or mutations that interfere with folate transport. Either way, if we're not bringing enough folate into cells, that's going to slow down the rate of DNA synthesis. So it's the same thing here. All these are doing is slowing down growth, division, and making it so that the neural grooves don't meet. So when our cells don't grow and move, neurulation is impaired, and we have these open neural tube defects. Now, if our neural tube doesn't actually form and our nervous tissue is exposed to air, this dramatically increases the risk of infection. So that's a big problem if we have some kind of spina bifida with a protruding cyst. Of course, if the neural tube is wide open, well, if we expose our nervous tissue to air, that's going to kill it. So that's another serious consequence if it's actually an open, wide open neural tube defect. But any spina bifida with a protruding cyst increases the risk of infection. Tethered cord syndrome has its own set of issues. So this can be caused by, again, fatty growths like a lipoma. So these are not uncommon to see in tethered cord syndrome. Here's the cartoon schematic of that. This pulls the spinal cord downward rather than ascending up into the lumbar spine. It's hanging out down here. Another possible cause of tethering is scar tissue. And this could be from some kind of injury, or it could be from surgical repair of neural tube defects. So let's say we can see that a developing embryo has spina bifida. One of the ways that we address this is with surgery before the kid is born. That surgery is wonderful in that it hides the neural tube under the skin, but it can cause scar tissue. So following that surgery, we need to be careful and monitor for signs of tethered cord syndrome. And then again, it might also just be problems with secondary neurulation rather than primary. Maybe that filum terminale doesn't degenerate enough and now it's a little bit thicker, and so it pulls the spinal cord a little bit further down. Either way, if we have tethered cord syndrome, the consequences are about the same. That mechanical force pulling us downward puts pressure on blood vessels, and that decreases blood flow. And we can see that right over here. Here they're actually measuring blood flow in the spinal cord. Here's with tethered cord syndrome, and you can see they're measuring about the amount. Here's the heartbeat. Okay, so they're estimating only about 14 mils per minute per 100 grams of tissue. After they untether the cord, we're back up to about 40 mils per minute per 100 grams. So about a threefold increase in blood flow. If we have decreased blood flow, what's the problem there? Well, we're not going to be able to pay the bill. So we're going to have reduced ATP in our neurons, and that can then lead to, believe it or not, excitotoxicity. We can also put pressure directly onto the nervous tissue. So everything is mechanically gated to some degree. If you rub your eyes, you'll see colors. So if we're putting pressure on those spinal neurons, that can also excite them. So it might not be a reduction in ATP, but it might just be the pressure that then hyperexcites them. And so we'll see these motor, sensory, autonomic signs that progress because of the continued hyperstimulation of neurons. And finally, another issue that we find in neural tube defects are Chiari malformations. So there's a few Arnold-Chiari malformations. All you need to know is that In these, there's herniation of brain tissue into the spinal canal. That is, my brain stem is no longer just in the skull. It protrudes down that foramen magnum, putting pressure on the spinal cord and the brain stem. Now, the cause of this could be one of those open neural tube defects, like this myelomeningocele here, where the myelo, that is the nervous tissue, and the meningo, that is the meninges, are protruding in this cyst. Well, obviously, that's going to change where the spinal cord sits. That's going to put some pressure, right, pulling us downward here. If we're pulling the spinal cord downward, keep in mind that's connected to the brainstem, so we're also pulling the brainstem downward. And as you're probably already imagining, tethered cord syndrome can do this as well. It depends on how strongly the cord is tethered. So the more you pull the spine down, the more likely you are to have brainstem herniation. The problems are the same as tethered cord syndrome. Decreased blood flow. We can also put pressure on nervous tissue. That can stimulate them. And we're also going to put pressure on the ventricular system, leading to hydrocephalus. That's what's going on up here. These ventricles are enlarged, putting pressure on the rest of the brain. So when we increase that intracranial pressure, what do? Well, we could push on blood vessels, decreasing blood flow. That doesn't end well. This still leads to excitotoxicity. And we could also mechanically stimulate the neurons. Again, everything's mechanically gated to some degree. So we're not rubbing our eyes here, we're rubbing our brain with these enlarged ventricles. Both of these lead to excitotoxicity. Moving on, Down syndrome is caused by the presence of either a complete extra copy of chromosome 21 or a portion of chromosome 21. Here we can see the sort of typical appearance of someone with Down syndrome. So this fella over here on the left has kind of the typical facies that we would see. The enlarged protruding tongue there, kind of the flattened nose, and the sort of almond-shaped eyes. In about 100,000 live births, we'll see about 120 cases of Down syndrome, so fairly common. You'll certainly see folks with it. The major risk factor that we worry about here is advanced maternal age. And that doesn't mean you're elderly. It means you're 35 or above. So ladies, once you're 35, you are geriatric as far as reproduction is concerned. The pathophysiology of Down syndrome is to some degree straightforward and to some degree very complicated. So what causes the extra copy of chromosome 21 is what we call a non-disjunction event. That is, chromosome 21 fails to properly separate from itself during meiosis. So Down syndrome is what we call trisomy 21. That means there's 3 copies, so 3 little bodies of chromosome 21. This means not a true number of chromosomes. That's what an aneuploidy is. So we have an extra chromosome 21. The reason that advanced maternal age is a risk factor here is because women are born with all of their egg precursor cells that they'll ever have, and those eggs just stall in meiosis, and they stall in prophase 1. So here is where the eggs are sitting until they actually mature, one at a time, to allow for reproduction. So the older women get, the older these eggs get, and that is the longer that these chromosomes are sitting there, matched up. So the homologous chromosomes have more time to exchange more DNA and potentially stick together much more tightly. And in fact, the risk of non-disjunction events increases dramatically with increased age. So here we're looking at a few bins of maternal age, so under 20, 20 to 25, 25, 29, 30, 34, you get the idea here, right? So we're looking at about 5-year bins of maternal age, getting older as you go from left to right. Let's look at the green line first. This is the incidence of Down syndrome per 100,000 live births. And you'll notice a dramatic uptick as we get into advanced maternal age, which starts here in these final 3. And that's why pregnancies for women 35 and older are monitored much more closely, because non-disjunction events are more likely. Not just for chromosome 21, for any chromosome. We happen to tolerate an additional copy of chromosome 21. Other aneuploidies are generally fatal, leading to spontaneous abortion. So despite this dramatic increase in the risk of Down syndrome, women above 45 actually contribute very few cases of Down syndrome. Most of them come from women who are not in advanced maternal age. And the reason for that is just simply the number of births. A lot more women have children before they're 35 than after. And so it's just a numbers game. But the risk is most certainly real once you're 35 and older, so there'd be a lot of diagnostic testing throughout those pregnancies. Now, chromosome 21 might be a little chromosome. There it is right here. So here's a karyotype from someone with Down syndrome. And even though it's little, that doesn't mean much, right? Because it still has 200 to 300 genes, and guess what? Those genes can go mess with other genes. So the problem with Down syndrome is what we call gene dosage. It's exactly what it sounds like. It's the dosage that you have of each gene. So if we have an extra copy of chromosome 21 hanging around, that means that we have 50% more of our chromosome 21 genes. So that'll obviously screw up their function because they're present in higher amounts. But the other chromosomes aren't spared because chromosome 21 makes things like transcription factors. And those are proteins that can stimulate the expression of genes on other chromosomes. For this simplified cartoon, I drew an arrow up to chromosome 9, but it works on other chromosomes too. So we have an extra copy of chromosome 21, but hey, we're also going to express more chromosome 9 genes. Or maybe fewer chromosome 20 genes, because I drew the blunt arrow over here. So we have transcription factors, that's the proteins that can change gene expression on other chromosomes. And we also make microRNAs. Those are RNAs that affect gene expression on other chromosomes. So whether it's protein, RNA, doesn't matter, chromosome 21 can go in and mess with expression on any other chromosome. As expected, this creates widespread problems in function from head to toe. I'm going to focus on the problems in the head, but we'll hear more about the rest of the body in the following lecture when PT implications are covered by Hannah. Okay, so one of the big problems in Down syndrome is early onset Alzheimer's disease develops almost invariably. So there's a much higher risk of Alzheimer's disease, and it comes on way earlier than in folks without Down syndrome. The explanation here is very straightforward. There's a gene on chromosome 21 called the amyloid precursor protein. So this is on chromosome 21. Rather than having 2 copies of the amyloid precursor protein gene, we have 3. So we have 50% more amyloid precursor protein. And that gene is exactly what it sounds like. It's a protein that's the precursor to amyloid, those plaques that show up in Alzheimer's disease. Well, those are made from a little portion of APP called A beta. They've color-coded this nicely, so there's A beta sitting right there in APP. So that means we have 50% more A beta floating around. And what we're going to find here is that A beta does a lot of nasty stuff. Sure, it can form these plaques that lead to inflammation and reactive gliosis, but it can also stimulate NMDA receptors, leading to excitotoxicity. Okay, that sucks. We have another problem though. Remember, those genes on chromosome 21 can influence genes on other chromosomes. And that's where tau comes in. So tau is the other protein in Alzheimer's disease where we see pathological hallmarks. And those would be these neurofibrillary tangles. These are protein aggregates inside of cells. The plaques are outside. Okay, so what's going on here? So that extra copy of chromosome 21 increases the amount of 3-repeat tau that we make. All right, 3R, 3-repeat, 4R, 4-repeat. And those repeats are the microtubule binding domains. So we make a version of tau a lot more frequently that doesn't stick to microtubules as well, right? We've got an increase in this 3-repeat tau. That leaves it off of the microtubules and able to be phosphorylated and then form these little aggregates, the neurofibrillary tangles. Even though tau is not on chromosome 21, it's still affected because there are little soluble factors that can go and mess with other genes. So we've got 50% more A beta, and we make a version of tau that tends to come off of microtubules and stick together. We're going to revisit this in just a little bit. Now, here we can actually see plaques in a 47-year-old male with Down syndrome. So we're looking at a slice of his hippocampus here, and notice all these dark aggregates. Those are the plaques. This is not what a 47-year-old's hippocampus should look like. This looks very much the same as an 88-year-old female with Alzheimer's disease. So over twice, nearly twice this gentleman's age. About the same number of plaques here. So this is early onset Alzheimer's disease. Here we're just looking at any A beta, so we can just see plaques. And these are kind of late stage plaques, if you will. So that means that this gentleman here has been making a lot of A beta for a long time, and we know why. He has an extra copy of the amyloid precursor protein gene. All right, before we touch on the importance of those, one last thing. Neurons in Down syndrome are a little more excitable because there's another gene that gets screwed up here, okay, and that's the sodium, potassium, chloride cotransporter. It's a mouthful, but here's the deal. This is a protein that brings chloride into the cell. And we make about 150% of the amount that we should in Down syndrome. So we make 50% more. Okay, that means that cells have more chloride inside them. All right, what's the issue there? So GABA, if you'll recall, is an inhibitory neurotransmitter. When it binds to its receptor, it opens up a chloride channel. That's what the GABA receptor is. It's a little chloride channel that's going to allow chloride to flow into the neuron, making it more negative. In other words, hyperpolarizing. And the reason that happens is because the chloride concentration is very low. There it is right there. You can't even see it. So we have a very strong concentration gradient pushing chloride into the cell. Okay, what if we had another cell over here that just had a whole bunch of chloride cotransporters and got filled up with chloride? Now what happens when GABA binds? Rather than entering, chloride leaves, making the cell less negative. That is, it depolarizes it. Now, is this real? Probably. All right, let's have a look over here. So we're recording in the hippocampus in a wild type mouse, and over here's a mouse model of Down syndrome. Okay, let's apply some GABA. Here we're just looking at spontaneous activity. We see a couple blips here and there. Give it some GABA, nothing. This is silence. Give it a little more GABA, surprisingly, it's still silent. Okay. Down syndrome model over here. Here we can see some spontaneous activity and quite a bit more than over here. Okay, let's give it a bit of GABA. That should quiet it up. Ooh, that doesn't quite quiet it up, does it? Let's give it even more GABA. That should work. Oh, man, look at this. Now the neuron is off to the races. This is crazy. GABA is now excitatory. GABA is the neurotransmitter used to inhibit neurons in the brain. Well, at least the forebrain. So now we've lost our ability to inhibit neurons. As you might imagine, this is going to increase excitability, potentially leading to excitotoxicity. And these are just some data showing us that, hey, if we look at the amount of that sodium, potassium, chloride cotransporter, yeah, there's about 50% more in folks with Down syndrome. So this is from humans. And if we look at their hippocampus, we see fewer neurons. That's what they're counting over here. Here's a stain for nu-N. That's a neuronal nuclear marker. That's what nu-N means. So all these little brown things, those are neurons, and there's just fewer neurons. Why? Well, because they were filled up with chloride and GABA was excitatory, and so they just died from excitotoxicity. So let's put this all together then. What's going wrong in Down syndrome is likely some glutamate toxicity for several reasons. First of all, we got more APP, we make more A beta, and A beta stimulates NMDA receptors. Also, those plaques create reactive astrocytes, which then don't pick up as much glutamate. And then finally, we got more chloride inside. So now GABA is not inhibitory anymore. So we apply the gas, and we don't take our foot off the gas, and we turn the brake into another gas pedal. So neurons are highly excited in Down syndrome. Another problem is impaired neurotrophic support. Remember, we make that less sticky tau, the tau that doesn't stick to microtubules, but instead sticks to itself, forming tau tangles. Okay, so that tau that's floating around in the cytoplasm gets phosphorylated, that's the p-tau, and that phosphorylated tau forms tangles. What's the problem there? Those tangles interfere with axonal transport. So we're unable to transport activated neurotrophin receptors back to the cell body. Here's some data that show us this. So what they're doing is growing some neurons over here. They got a couple of gaskets to seal them off. They can grow their axons through those gaskets and into this region of the dish. Here's the cartoon version. Cell bodies over here. Axons grow through this red part, and they deliver some NGF, that is nerve growth factor, to this part of the dish. Nerve growth factor can't diffuse over here because they got a gasket in the way, but it could be picked up by neurons and transported through retrograde transport. And that's what we're seeing over here, the amount of NGF transported. And this is just control mice, nothing to see here. Down syndrome model with an extra copy of APP. 2 copies of APP over here. Transport still is slowed. Add that extra APP, slowed even more. Hey, wait a second. I didn't mention APP over here. What's the deal? Have I been lying to you? No. I was waiting to draw this arrow. Guess what? When you have more A beta, that leads to extra tau phosphorylation and actually promotes the formation of tau tangles. So it's all connected. I haven't lied to you too much yet, I think. Whether it's glutamate toxicity or impaired neurotrophic support, doesn't matter. Both of those things will cause neurons to lose synapses and eventually lose their life. And that will explain the cognitive impairments that occur in Down syndrome. Finally, we have Prader-Willi syndrome. Whereas Down syndrome was an extra copy, Prader-Willi syndrome is a missing bit of chromosome. Different chromosome, chromosome 15. But again, it's not an excess. It's a lack of. All right. Not the whole chromosome 15, but just a part of it. Here it is right here. The Prader-Willi syndrome region of chromosome 15. So you can see, less common, but also presents differently. So here we're going to see short stature. All right, so we won't be as tall, and we're going to also see dramatic weight gain. So we'll be wider. So shorter and wider. Risk factors, still advanced maternal age. Non-disjunction events can lead to this, as we'll see in a little bit. And a family history, that can also contribute. But you'll see 95% of the cases actually don't have a family history. All right, what's going on in Prader-Willi syndrome? Different chromosome. So we're looking at the Q11 to Q13 arm of chromosome 15. Do you care about that? No. But we should probably know that it's chromosome 15. The only reason that that portion of the chromosome matters is that it contains these, what we call paternally imprinted genes. What that means is that only dad's version gets read. So you get one copy of chromosome 15 from mom, that's over here, and one copy from dad, that's the paternal one. Mom's chromosome 15 is hypermethylated in this region. That's what's going on right here. Here we have methylation of the DNA, and that compacts it or condenses it, so we can't read those genes. Even though mom gave us the genes, we're not going to read them because we can't. The DNA is too condensed. If you want to read a book, you got to open it. Here, we can't open the book. It remains closed. So only dad's genes get expressed. This is a problem if dad maybe doesn't give us those genes because of a deletion. You can see this is a fairly common cause of Prader-Willi syndrome. Little deletions in chromosome 15. Another possibility is that we end up with 2 copies from mom and none from dad. Now, you might be thinking, how in the heck could that happen? Well, there was a non-disjunction event. Okay, this is called maternal parental disomy. So it's not a trisomy, but it starts off like that. Mom gives us 2 copies of chromosome 15. So let's put mom's over here. And then dad will give us this blue one. All right, so there's the paternal, and here's the maternal. And that was caused by some non-disjunction event. Advanced maternal age, right? Okay, so we got other chromosomes. We just don't care about them for here. So we got our cell here, our fertilized cell. It's got 2 copies of chromosome 15. Ooh, chromosome 15 is a bigger chromosome. And here's the deal. We don't tolerate trisomy 15. So this will kill you. The only way you can survive is by getting rid of one of those chromosomes. And so the cell actually removes one chromosome. And, well, if by chance we remove dad's, we're left with 2 of mom's. And that is what's accounting for this minority of cases over here, where we have 2 maternal chromosome 21s. Least common of all, we have mutations that cause some kind of imprinting defect. So there are mutations on the chromosome that makes it get imprinted, makes it get methylated. Even though it came from dad, we're going to treat it like it's from mom's. We can't tell, and so we hypermethylate it. In either of these, either we're missing it, we're missing this segment of the chromosome, or it's hypermethylated for one reason or the other, we won't express those genes. And that's going to cause a bunch of problems. We're going to summarize them into kind of 2 general classes. What explains Prader-Willi syndrome pretty well is hypothalamic dysfunction. And indeed, you can see some neurons in the hypothalamus are decreased, not all, but some. So there's some signs that the hypothalamus is affected. And it makes a lot of sense because of the symptoms that we see in Prader-Willi syndrome, right? We see hyperphagia, hypogonadism, hypersomnolence, and that short stature there. So they're really hungry. They eat all the time. The hypothalamus controls our appetite. And so if we're missing those neurons that make us feel full, well, we just don't feel as full. Therefore, we feel hungrier all the time. If we're missing those neurons that release gonadotropin-releasing hormone, well, then that would explain the hypogonadism that we see. If we're missing the neurons that stimulate growth hormone-releasing hormone, well, that would explain the short stature. We're not going to grow as much. If we're missing parts of the sleep-wake circuitry, well, that would explain the hypersomnolence there. And indeed, there's some good evidence for this. So if we look at orexin, this is a peptide derived from the hypothalamus. Folks with Prader-Willi syndrome have orexin levels somewhere between folks with narcolepsy and folks with typical orexin levels. So there's a reduction. They have about half of the normal level, we'll say. Orexin wakes us up. And so if we don't make as much orexin, we're going to sleep a whole lot more. Now, there's also signs of peripheral dysfunction as well. I hate to say this, and I'll deny that I've said it, but the brain isn't everything, okay? We also see changes in peripheral hormones, and the one that I'm going to highlight here is ghrelin. All right, ghrelin stimulates our appetite. So when your stomach is grumbling, you're releasing ghrelin. That's how I remember it, because I need that kind of stuff. Okay, here we got a table. We got 4 columns. So non-obese females, obese females. So the first 2, we're not dealing with Prader-Willi syndrome. We're just seeing how things change with obesity. And then we got Prader-Willi females and males. All right. This table isn't too interesting until we get to the end. It shows what you'd expect. Despite similar height, people who are obese over here have more weight. Of course, that's how we selected them. So they'll have more body fat, and accompanyingly, they have less ghrelin. Right? Ghrelin is released to stimulate appetite, and boy, wouldn't it make a lot of sense that if you're obese, you don't have as much appetite. And ghrelin is only released by empty stomachs, so if you're obese, you're probably less likely to have an empty stomach. So this makes good sense. In obesity, we should see a drop in ghrelin, and indeed that's what we do see. And hey, in Prader-Willi syndrome, we see obesity, so they should have a lot less ghrelin, and that says, whoa, wait a second, we're seeing about twice the level of ghrelin that we should in our controls, and like way more than twice the amount in females that have similar degrees of obesity. In fact, we have even more body fat and a slightly higher BMI, yet we have a whopping amount of ghrelin floating around. So that would explain the hyperphagia as well. Why do they eat a whole lot more? Could be problems with the hypothalamus, and I'm going to stick by that one, of course, because, the brain is everything. But it could also be that other hormones are altered, and just simply making a whole lot more ghrelin makes them feel hungry. Despite how much they eat, they still put out ghrelin. In folks without Prader-Willi syndrome, after you eat, you stretch your stomach, it stops releasing ghrelin, and you feel satisfied after that meal. Now, in case you don't feel satisfied with your understanding of any of these topics, please do take the time to fill out that questions box so I know what to talk about in class. I'll see you there.